这个 Okay, so let's get started. Um, Hello, everyone. Welcome to our today's Amy Zoom seminar. It's my pleasure to welcome our today's speaker, Dr. Shi Kaibin from Department of Neurology, Beijing Tiantan Hospital, Capital Medical University. At the same time, also Kaibin also served a physician scientist in Institute of for Immunology, Chinese Institute for Medical Research. So Kaibin actually completed his MD training in Tianjin Medical University, and then continue with a postdoc training in Barrow Neurological Institute in St. Joseph Hospital and the Medical Center. Then he returned to China and then started his residency in neurology in Tianjin Medical University General Hospital, and then Beijing Tiantan University, Tiantan Hospital, Capital Medical University. So, as I mentioned, currently Kaibin is a neurologist specialized with patient with MS, neuromyelitis, optica spectrum disorders. And then same time, he also has his independent research program as assistant professor in Chinese Institutes for Medical Research. So his work actually really cover a broad spectrum of neurological disorders, and he studied the specific features of initiation, progression of inflammatory and immune responses of central nervous system, as well as cerebralic modulation of neural inflammation in patients with MS and stroke. Also corresponding to studying the animal models. His work contributes to discovering the role of bone marrow in deriving neural inflammation in chronic brain injury, as represented by patients with multiple sclerosis, as well as acute brain injury, such as stroke. Um, I think his research program and research lab dedicate to explore new strategies for treating neurological disorders through targeting bone marrow hematopoiesis system. I think Kaiping really accomplished quite a lot, both academically and also clinically, with different different accomplishment. He was received numerous awards. I just list a few. He got in Beijing Talent Awards and also Young Talent Award, Chinese Stroke Association. I think 2024 he got Young Scholar Awards from Chinese Society for Immunology. So I think probably Kevin going to tell us today about his recent work related both clinical and research side for myelopoiesis in neurological diseases. So thank you so much, Kaibin, being with us today, and then we are very much looking forward to your talk.
Thank you, Dr. Wu. Very thanks for this invitation and the kind introduction. And my group and I really benefit a lot from listening to this wonderful series. So today I will introduce some work from our group in recent years. So the basic logic in our group, what we're doing is to study the interaction between the central nervous system and our peripheral immune system. As we know, any organs of our immune system and any tissue are actually highly innervated by nerves derived from our central nervous system. So any injury or any change of the microenvironment in the brain can be quickly related to our peripheral immune system, and can these systems can quickly respond to the injuries that happened in the brain or the spinal cord. And at a response, these motivated immune cells can then home into our brain, and these cells can then further be modified in the specific microenvironment of the brain provided by focal cells. And today, the work in our group in the last years, actually we focusing on the bone marrow hematopoiesis system. As we know, the bone marrow is the only hematopoiesis tissue in adult subjects, and it sustains the renewal of all our immune cells in the peripheral blood, and it provides the resources of all cells all in the immune system. And the work from recent years has just broadened the role of bone marrow in our health and disease conditions, as it's not just play as arsenal to just provide this weapons for our immune system to combat the infections and the diseases, but it's also actively participating in many conditions like including infections and acute injuries in myocardium and also stroke and acute brain injury. And it's also a very important part to keep our immune memory to protect the memory cells in our system. So today, our work actually focusing on the cells that are located in the bone marrow, that how HSCs give rise to myeloid cells and the lymphoid cells. And from the clinical perspective, we are interested to know how this system reacts to neurological diseases, including chronic inflammatory disease like multiple sclerosis as well as acute brain injury. So the first part of my presentation today will look at the impact of bone marrow responses to MS and chronic neuroinflammatory diseases that mainly causing the young people disability worldwide. And because it's autoimmune feature, it's continuous relapse and remitting with chronic progression of neurological deficits. This MRI slide shows the characteristic the typical lesions in the patient of MS, which showing the demyelination plaques that are located close to the ventricles, and also chronic brain atrophy that indicating these patients develop the neurodegeneration. The pathology of MS for the past three decades, a great breakthrough is the identification of myelin reactive T cells that be activated in the peripheral blood and their migration to the central nervous system and causing demyelination and causing neuroinflammation and demyelination and axon injury. And if we look at the distribution of lesions in MS patients, it can broadly impact the whole CNS system, including optic nerve, cerebral cortex, brainstem, and the spinal cord. So the appreciation of the role of myelin reactive T cells in the pathogenesis of MS has have boosted the development of disease-modifying therapies in the past 2 decades. And if we look at this treatment, there's mainly targeting the peripheral immune cells, mainly T cells and B cells, either blocking their motivation or blocking them or inhibition of their migration or infiltration to the CNS, or we can just deplete B cells in the peripheral. We notice that these all drugs mainly target the peripheral T cells and B cells. And with the helping of these high efficacy treatments in the past 2 decades, we now can well control the relapses of these patients. However, when this risk now can be well controlled for these patients, previously ignored or very subtle aspects of the disease has become more obvious. We call it PIRA. What I mean is disease progression independent of relapses. That means even there is no relapses in these patients during this period. For example, there is no synapses, but the neurological deficit still declines in these patients. And for all this current treatment, the period responds poorly to current therapies. So based on these observations, we previously proposed that the disease course of MS patients may be driven by two forces. The first one is what we have highly appreciated is the peripheral immune response that mediated by T cells and B cells, which causing relapses in these patients. And another force is chronic and continuous intrinsic neurodegeneration, which can occur very early in the disease stage. But the mechanisms are still not very clearly investigated, and the current therapies are ineffective for disease progression in these patients. And if we roughly MS patients, we can roughly classify them into two types of lesions. The first one is active lesion, which mainly caused by activated T cells and B cells, the migration to the brain, and which are targeted by the current therapies and can be well controlled. However, the other one is chronic lesion that causing neurodegeneration and the disease progression. And the myeloid cells play a major role as suggested by the pathologic studies, but currently we have no highly effective therapies to combat such compartmentalized neuroinflammation to slow down the disease progression, progression of the disease. And the other part I want to introduce before showing our own data is the HSC transplantation. As the appreciation of autoimmune T cells in the pathogenesis of MS patients, there has been a decade trying to using hematopoietic stem cell transplantation to restore the peripheral immune system to treat these patients, especially for those refractive patients that respond very poorly to current therapies. Even though these are conducted in very small scale clinical trials, but several trials collectively has suggested that hematopoietic stem cell transplantation can be higher effective in limiting the disease activity, and more interestingly, it slow down the disease progression as referred by the increase of the disease score, and even it can showing a little bit trend in improvement of the neurological deficit. However, even we have this clinical evidence, but till now we don't know how the bone marrow features of MS patients showing, and whether or how these bone marrow immune responses contribute to the disease progression or neuroinflammation. And to answering this question, the first work from our group is to we collected the bone marrow samples from our MS patients and using single cell RNA-seq to characterize the bone marrow immune landscape in our MS patients. We surprisingly find out that in our MS patients, the hematopoietic stem cells are largely expanded in the bone marrow of MS patients, and together with myeloid cells, including monocyte and neutrophils, are increased in the bone marrow of MS patients. This suggests that there might happen aberrant myelopoiesis in the bone marrow of our MS patients. And this phenomenon was then confirmed in our mouse model and EAE model and MS model. And we further using transgenic hematopoietic stem cell non-tracing mice to in which we can induce tomato expression in newly generated HSCs by tamoxifen treatment, and after which the downstream cells that rise from these HSCs will all be labeled by TD tomato. And then we can clearly find out that in the bone marrow of these transgenic mice after EAE induction, we can identify newly generated neutrophils and monocytes are increased, and these cells can readily migrate and infiltration to the CNS and causing neuroinflammation. And then we are interested into what is the driver of such bone marrow responses in MS or EAE mice. As we know, a major driving force of MS or MOX35-55 EAE mouse is autoreact T cells. We then want to answer whether these autoimmune T cells are homing or concentrate or accumulated in the bone marrow in EAE mice, and we applied a tetramer to detect such autoreactive T cells. When we surprisingly find out that the proportion of many reactive T cells in the bone marrow is even higher than lymph node and peripheral blood, which has previously been recognized as a main space where the with these autoreactive T cells being generated and play roles. And then we're using a transgenic mice model, 2D2 mice, which T cells can react can be reactive to MOG35-55 can automatically react to MOG35-55. And we isolated the CD4 T cells from this mice, and after peripheral activation, and then transfer to RAC2 knockout mice. And we show that transfer of these T cells, only T cells can readily boost the bone marrow myelopoiesis with increased the myeloid progenitor cells, and as well as neutrophils and the monocyte. This suggests that 22 T cells or these many reactive T cells can readily activate the bone marrow response we observed in our mice. And then we want to delineate how these T cells boost bone marrow myelopoiesis. We sorted out 22 T cells from 22 mice and performed an ELISA array, and we found out in these T cells, we surprisingly found out that CCL5 is the most highly expressed cytokine in these T cells, and which was also then performed by flow cytometry. And then whether CCL5 is the main driving of HSC myelopoiesis, we then analyzed whether CCR5 are expressed in our in the HSCs of 22 mice. We performed an RNA-seq of the HSCs isolated from 22 mice, and we can find out that CCR5 actually are highly regulated in the hematopoietic stem cells of our 22 mice, which was also then confirmed by flow cytometry. But how CCR5 are being involved in such a myelopoiesis system? We then go back to the literature, and we find out that actually the expression of CCR5 is kind of aging features of our hematopoietic stem cells, and which contributed to skewing of hematopoietic stem cells, giving rise to increased myeloid cell generation observed in aged mice. And with this appreciation, as we kind of collect that, what we observed in our MS patients' bone marrow, which is partially like the myelopoiesis that's being observed in aged subjects. And the increased CCR alpha and 2 CCR alpha, I think, was also confirmed in our MS patient bone marrow. So then we using a translate and chimeric mice to generate CCR5 knockout HSCs in these mice, and we demonstrate that if we knock out the CCR5 in bone marrow, it can reduce or inhibit the generation of myeloid project cells, as well as the output of mature myeloid cells, including neutrophils and monocytes. And also, this might show the improved neurological deficit and the inflammation of the spinal cord and ameliorated demyelination. So, in a brief summary, in this work, we identify that these myelin react T cells can home into our bone marrow, which give rise to which activated our HSCs to minor cell generation via CCR5 to CCR5, and demonstrates that the CCR5 might be a potential therapeutic target in MS. And following this work, collaborated with Professor Liu Hong from Shanghai Pharmaceutical Institute, we developed a novel CCR5 inhibitor, we named it CIMR, and we tested its efficacy in preclinical animal models, and this drug has now been approved by Chinese FDA for clinical trials. And a phase 2 trial, we named it MS, means CIMR for treatment of MS, has been planned. So this is the first part. We demonstrate that the bone marrow myelopoiesis system actually drives the neuroinflammation and disease progression of MS patients. And the other part I want to share today is the contribution of bone marrow myelopoiesis system to acute brain injury. As we know, after acute stroke or trauma, a big and acute injury of the brain tissue occurred, which can subsequently activate a cascade of neuroimmune responses, and are closely associated with the disease outcome of this injury. And this is a brief introduction of acute brain injury, including the ischemic stroke and hemorrhagic stroke and trauma. Are all with higher incidence burden in China. So the first work we in patients with intracerebral hemorrhage with bigger hematoma, we can collect in these patients who received surgical treatment, we can collect their scar flaps and flush out some bone marrow samples. And with these samples, we characterize that actually at the very acute phase of disease, as early as 1 day, just within 1 day of the occurrence of the acute injury, we clearly identify that the hematopoietic stem cells are increased in the bone marrow of these patients, and very interesting, we also identified that the myeloid progenitors are also increased in the bone marrow of patients with intracerebral hemorrhage. But the progenitors of lymphocyte progenitors are inhibited or decreased. And these observations were also then confirmed in our mouse model induced by intracerebral hemorrhage. We identify the hematopoietic progenitor cells and the long-term hematopoietic stem cells are increased during the acute phase of ICH, and with increased proliferation activity as all with we using a PET-CT to identify that the spine bone marrow activity are increased after acute being after intracerebral hemorrhage in this mouse. And also, similarly, using this transgenic mouse model, we not only traced the increased HSCs, and we shown that this increased HSC is actually giving rise to mainly a subtype of monocyte. We name it L160 no monocyte, or in patients it's we name it petroleum monocyte or alternatively activated monocytes. This kind of monocyte, as we know, or if you are familiar with monocyte, we know that these kind of monocytes are mainly contributed to the clearance of tissue debris and also modulation of focal microenvironment. And we find out that this subset of monocyte actually are highly express IL-10, which we know has the immunomodulatory features. And a brief summary of this work, we identified that the acute brain injury caused by intracerebral hemorrhage can activate our bone marrow hematopoietic system via sympathetic nervous system, and contributing to the generation of IL-10 positive monocyte. And this monocyte can modulate the acute neuroinflammation in the surrounding in the perihematoma area, and improve the clinical outcome of such acute brain injury. And in the following work, I will not introduce more. Is that we identified that such features are impaired in aged patients, which are partially associated with the poor clinical outcome of aged patients with acute brain injury. So the next part is that in the clinical setting, when we management of a patient with acute brain injury, especially for the inpatient in our ward, and a large proportion of this patient will develop stroke-associated complications like infection, and major our efforts actually are contributed to the management of these complications in our stroke patients, especially the stroke-associated pneumonia that I will pay much attention to in my following presentation. Stroke-associated pneumonia occurs in nearly 10% of stroke patients, which become even higher in severely injured patients, and also in patients that within the intensive care unit. And we, as a physician, we are very concerned. We're concerned about the stroke-associated pneumonia because it's can definitely increase the mortality of this patient during the acute phase, as well as worsen the neurological symptoms of these patients. However, in the two large clinical trials that published 10 years ago, using a prophylactic antibiotic is the most powerful tools that we can human can use to combat infections. However, both these two trials failed to show that these antibiotics can prevent the occurrence of stroke-associated pneumonia or improving the outcomes of this. And this is a comment in the journal by the after the two trials are published, and they propose that the results of these two trials suggest that the stroke-associated pneumonia might be partially a pneumonitis, and with more non-infective inflammatory components may contribute to the occurrence of stroke-associated pneumonia. But what is it? In the past 2 decades, joint forces from our group and as well as other groups in the world, we characterize the immune response post acute brain injury. And I want to stress that just after the very acute phase, during the subacute phase, maybe 24 hours or even earlier, and so our brain injury can shut down our peripheral immune system to immunodeficiency status, as shown by the atrophy of lymphoid organs, as well as the lymphopenia and the dysfunction of our lymphocytes. And we kind of think kind of collected that such lymphopenia or immunosuppression status may contribute to increased infections risk of these patients. And and phase 2 trial from our group to demonstrate that using an beta blocker to block the neurogenic signals to our immune system to protect our lymphocyte to prevent the infections is now still ongoing. However, besides this, if we further go back to the occurrence of stroke associated pneumonia, it mainly takes place within days 2 and 7. However, the lymphopenia or the immunosuppression, as I just mentioned in previous slides, which is become very obvious during day 3. So what happened before the occurrence of stroke associated pneumonia and before the occurrence of lymphopenia or immunosuppression? What happened at the very acute phase now, which haven't been tested in previous studies? To answer this question, we previously using we collected patients with acute ischemic stroke, but during a very acute phase with no any symptoms of pneumonia or fever or upregulation of peripheral white blood cells. But some of these patients may need to do a broncho machine supported the breath, and we have a chance to collect the broncho iron the white fluid of these patients. Using single cell RNA-seq, we showing that compared to controls in our stroke patients, in the control subjects, there's a large amount of alveolar macrophages in the BARF. However, in our stroke patients, this changed to neutrophils. There's a great number of neutrophils accumulated in the BARF of our stroke patients. When we compared the phenotypes of our neutrophils in stroke patients compared to its paired peripheral blood, we're showing that these neutrophils that accumulated in our lung actually are highly pro-inflammatory and permeability with upregulated I1 beta and VEGF-A. And then this observation was further confirmed by flow cytometry of BARF collected from stroke patients, which showing that neutrophils are the #1 cells that are accumulated during the very acute phase of stroke, but during which the patient are still absent of symptoms of pneumonia. And a more interesting part of this data is that we identify that in the neutrophils that accumulate in the BARF of our stroke patients, over 1/3 of these neutrophils are immature neutrophils, suggesting that these neutrophils are just be generated from progenitor cells. And then we go to mouse model induced by middle cerebral artery occlusion. And we also show that in the lung tissue of these mice after MCLO induction, the neutrophils in this lung are obviously increased other than compared to other cells. And also, the immature neutrophils proportion are also increased in the non-tissue of our mouse. And then we want to know whether these neutrophils causing the acute lung injury and subsequent pneumonia occurrence in our mouse model. And we depleted these neutrophils before model induction and by an antibody targeting L16G. And we're showing that in mouse that be depleted with neutrophils, the acute lung injury during 1 day and the subsequent pneumonia at day 3 are also improved in these mice. This suggests that these neutrophils does contribute to acute lung injury and the subsequent pneumonia. And then a more interesting question that we are interested is that where is this neutrophils come from? As we know, the lifespan of neutrophils are very short, and we identified over 1/3 of neutrophils in the BARF or in our stroke model in the lung of our mouse are immature neutrophils. Then we propose that whether the myelopoiesis happening in the lung that contributed to these immature neutrophils. To answer this, we first detect whether these projected cells can be detected in the lung tissue of our mouse, and we collected the lung tissue of MCL mice, and we clearly detect that a population of long-term hematopoietic stem cells, as well as myeloid projected cells, are increased in the lung tissue of MCL mice. This suggests that this HSA might contribute in situ minus of neutrophil generation. But whether these hematopoietic stem cells or projected cells can functionally generate neutrophils in the lung tissue. To answer this, we isolated the CK positive cells from our lung tissue of MCL mice and seed these cells to an OP9-DR1 cells that can support hematopoiesis in vitro. And after 7 days, we clearly identify that CK cells isolated from our MCO mice can form a clearly hematopoietic cluster, demonstrate that these cells can generate blood cells in vitro, and these cells are functionally hematopoietic stem cells or projected cells. And then also the flow cytometry showing that the neutrophils are increased in these cells. And then we are interested in how these HSCs move into the lung after stroke. Our stroke lung itself has HSCs, or these HSCs actually migrate from bone marrow or other places to the lung after stroke. To answer this, we performed a parabiosis of wild-type mice and T-tomato mice. And after 2 weeks, we induced brain injury in these wild-type mice. And after 1 day, we detect whether the T-tomato positive cells can migrate to the lung of these mice. And we clearly showing that after 1 day, 1 day just after the MCO induction, we detect that the T-tomato positive HSCs are increased in the lung tissue of these white mice, which suggest that the T-tomato positive HSCs might migrate from the bone marrow of T-tomato mice to the lung tissue of these white pairs. And also we detect that the myeloprojected are also increased. T-tomato myeloprojected cells are also increased in the wild type lung after MCO. And very interestingly, these motivated T-tomato positive cells are selectively accumulated in the lung, as shown in this slide. But when we look at the bone marrow, these cells are nearly detected in the bone marrow of these cells of the white mice, suggesting that these HSCs are hardly selectively mobilized to the lung, but not other tissue, even not bone marrow. So what is the molecules that are tracking this HSA from bone marrow to the lung? We first screened that the conventional cytokines that has been known are involved in the retention or migration of hematopoietic stem cells, and we showing that the conventional something like CXL12 KIT ligand are highly activated or highly upregulated in the bone marrow. However, the CCL2, which we all know is we all know is a major chemical recruit monocytes, which are highly activated upregulated in the non-tissue of our MCL mice, but not in bone marrow. And we showing that we are interested to find out that in the HSCs we isolated from our lung, and this HSC, nearly all HSC in the lung express the CCR2. That suggests that CCL2 to CCR2 axis may contribute to the migration of hematopoietic stem cells from bone marrow to the lung. And to demonstrate this, we then generated CCR2 knockout mice with a CD45.2 CCR2 knockout mice with CD40.1 white mice. And we're showing that these CCR2 knockout hematopoietic cells are failed to migrate to the lung. This suggests that CCR2 is responsible to the migration of bone marrow hematopoietic stem cells to the lung. And also, pharmaceutical blocking of CCR2 can inhibit the increase of hematopoietic stem cell numbers in our lung, and as well as downstream myeloid progenitor cells, as well as neutrophil counts in the lung, and also ameliorated the acute lung injury and the subsequent pneumonia. So, as we know that the differentiation of hematopoietic stem cells to either neutrophils or monocytes or lymphocytes are actually driven by different transcription factors. So we are then keen to know what transcription factor that drives those non-HSCs differentiation to neutrophils in the lung. To answer this, we sought the LSK cells, mainly in the hematopoietic stem cells and the progenitor cells. And we performed bulk RNA-seq to show that genes that associated with myeloid cell differentiation are highly upregulated in the non-LSKs compared to sham control. And the analysis of transcription factors that may driving such myeloid cell proliferation, we focusing on 3 transcription factors that are highly suggestive of myeloid cell generation. And then we tested these 3 transcription factors by using SRI to knock down the in vitro. The test of these three transcription factors, we only show that the knockdown the transcription factor cream actually inhibited the formation of hematopoietic clusters, which suggests that cream might contribute to the differentiation of neutrophils of non-HSCs, and more importantly, the differentiation of lymphocytes are not impacted by cream, which suggests that the cream as a key driver of generation of neutrophils in the by the non-HSCs. So in a brief summary, that in this part of study, we provide actually a novel mechanism frame to understanding the occurrence of stroke associated pneumonia. That means during the very acute phase, the accumulated neutrophils or the in situ generation neutrophils contribute to an acute inflammatory injury, which then impaired the alveolar structures and increase the susceptibility of lungs to infections, which contribute to the occurrence of stroke-associated pneumonia. By blocking such pathways can inhibit the generation of neutrophils and ameliorate the non-inflammation and prevent the occurrence of stroke-associated pneumonia. So in a brief summary, so in the past years, the work from our group mainly contributed to the discovery of bone marrow myelopoiesis system, contributed to the generation of neuroinflammation in acute brain injury, as well as its response to acute brain injury, as well as its contribution to the peripheral complications of stroke. And the understanding of such mechanisms can provide us opportunities to treat such diseases, and some of our discoveries, like CIMR5 inhibitors, now has been in the clinical trials. So I would thank my colleagues from Beijing Tiantan Hospital, as well as CIMR and the Tianjin Medical University in helping this project, as well as our collaborators from Vanderbilt Study and Nantung University, as well as 304 Hospital, and the fundings that support our work. Thank you very much, and I would like to take any questions.
Hello, Kaibin. Yeah, this is a wonderful talk. So many, so comprehensive knowledge about, information and hematopoiesis. For the audience, if you have any questions, please leave your question in the chat box, or you can just direct ask your question yourself. I'm gonna kick off the